Well, thank you, everyone. My name is Fatima Loren Dreyer. I'm Executive Director of the Health Alliance for Violence Intervention, and I lead the Kaiser Permanente Center for Gun Violence Research and Education. And I'm really excited for this panel, addressing gun violence through equitable research and collaboration. I'm going to actually ask the panelists to introduce themselves and to start us off with sharing a bit about your work, your area of interest, and how you came to be in this gun violence, address public health problems in gun violence. So, Ruth, I'll start with you.
Sure. So, good afternoon, everyone. It's an honor to be here. My name is Ruth Abaya. I am Senior Director for Health Systems and CVI Integration, Community Violence Intervention Integration at the HAVI, the Health Alliance for Violence Intervention. I'm also a pediatric emergency medicine physician at the Children's Hospital Philadelphia, where I work with the Center for Violence Prevention on a range of issues, and formerly worked in our local health department leading the injury prevention work there. My interest really starts with a clinical story where I was taking care of a patient who had had 2 firearm injuries in rapid succession in a short period of time, and really just bore witness to the revolving door element of trauma care. So that was the kind of nature of my original interest. But since then, I've become really interested in how kind of system integration can really support effective violence intervention and prevention. Having worked in academic medicine, having worked in the nonprofit sector, and then in public health, I've seen the unique contributions all of those sectors can play, and I'm really interested in how we can collaboratively answer questions about what really creates systems that are conducive to violence, and then how we address them. Thank you.
Great. Good afternoon, everybody. My name is Kristen Mizzi Angelone, and I direct the Pew Charitable Trust Suicide Risk Reduction Project. I just want to start by saying if you or someone you know needs help, please call 988, the Suicide Crisis Lifeline. It's available 24/7. It's free, it's confidential, and it's available. The Pew Charitable Trust is an international not-for-profit organization focused on advancing evidence-based policy solutions to some of our biggest challenges. We got into the suicide prevention field just in the last couple of years, really for 3 main factors. One, obviously, suicide is a public health crisis in the United States. After a dip in the suicide rate during 2019 and 2020, the last couple of years have had a record suicide deaths in this country. In 2022, almost 50,000 people died by suicide in the United States, which was the highest number ever recorded in this country. And more than half of those deaths, about 27,000 people, involved firearms. We are really focused on how to improve suicide care within the healthcare system, because research shows that about half of people who die by suicide have interacted with the healthcare system within about a month of their death. And so we really look at these interactions as just crucial intervention points to identify people who may be at risk of suicide and help connect them to care. And I should say, if you look within a year of suicide deaths, almost 90% of people who die by suicide have interacted with a healthcare provider, and the vast majority of those visits are not with mental health care providers. They're with kind of general practitioners. So we really want to look at how the healthcare system can be doing a better job of identifying people. And then the third reason is because there are evidence-based and evidence-informed interventions that the healthcare system can utilize, again, to screen and identify people who may be at risk of suicide, assess their level of risk and what type of care they need, and then, of course, connect them to follow-up care. Thank you for having me.
Thank you.
Good afternoon. I'm Joe Richardson, Professor of African American Studies and Medical Anthropology at the University of Maryland. Also co-director of Progress, which is a new gun violence research initiative at the University of Maryland, which launched in November of 2023. So the way that I came to this work is really personal. I'm from Philadelphia, born and raised. Sounds kind of like Fresh Prince of Bel-Air, but I'm not from West Philly. I'm from Uptown, to be exact. And I can recall at 13 seeing someone shot in front of me for the first time. And roughly, 2 years later, there was a young person that I looked up to in my neighborhood who was shot. He was actually the first person who I had known that had ever been shot. And after he was injured, his entire personality had changed. He became addicted to drugs in Philadelphia. We have a concoction called pancakes and syrup, which is promethazine, and Xanax, which is basically crushed into a mixture, and he started abusing that. And then ultimately, 2 years later, he was shot actually on my block. He was shot in the head and he was killed. And that always stuck with me. And so fast forward, maybe 2009, I'm watching CNN, Black in America, and there's a segment on a trauma surgeon at the University of Maryland Shock Trauma Center, Dr. Carnell Cooper, who was one of the pioneers for hospital violence intervention programs. And that was my first time ever being exposed to what a hospital violence intervention program did. And I was really fascinated by it. I cold called him, which I always do. And he happened to respond, and I told him I was interested in his work and could I follow him in his shop. And later that week, he invited me up. My first time there, I was on television. I was on the Discovery Channel, so I knew it was going to be cool because he was filmed every week. And I learned from him how hospital violence intervention programs worked. And ultimately, he transferred over to the University of Maryland Prince George's Hospital Center as a chief medical officer there. And I asked, could I use that trauma center as my lab? And followed 25 young Black men for a period of 2 years that had been shot. And from that study, I used that data to develop and implement an HVIP, which I founded at that hospital in 2016. And so thank you. And so that was really my introduction into this work.
Thank you.
Hi, I'm Daniel Webster, a Bloomberg Professor of American Health at Johns Hopkins Bloomberg School of Public Health, and I'm affiliated with the Center for Gun Violence Solutions there. I was getting my doctoral degree in health policy at Johns Hopkins in the late 80s, early 1990s. Our campus is in East Baltimore, and you could regularly hear gunshots and hear the sirens. And this was at the peak of what many people refer to as the crack cocaine era of gun violence that really devastated particularly young boys and young men of color. And I was sort of searching at that time. I was really intrigued by the power of public policy and public health to change conditions that determine whether people live or don't and the quality of their life. And I happened to be at a place where, it was sort of the first conversations about what is our role in public health to respond to this crisis. And it was clearly a crisis then, and it's a crisis now. I recognized all the many, many gaps that we have in addressing. In the city of Baltimore, if you looked at that time in particular, we just had a policing response period. That was the only thing we could offer for this tragic public health epidemic. So that was my entree into this, my motivation, and sort of seeing this as, frankly, if we are going to protect and advance public health in cities like Baltimore, there's literally nowhere way we can achieve that without addressing gun violence. That is what was so clear to me at that time that I continue to believe today.
Thank you. Thanks to each of you for your work. So I'm going to offer first some context for this conversation. Violence is the leading cause of death for young people in the United States. It has been the leading cause of death for young boys and men of color since the 1980s, African-American boys, the second leading cause of death for Latinos, young men. We at the Kaiser Permanente Center for Gun Violence Research and Education, as Dr. Benjamin mentioned, is a $25 million commitment that Kaiser Permanente has made, what we understand is a historic investment from the health sector to address this problem. That's that commitment, that investment is happening in the context of what's been a decades-long lack of investment in gun violence research. There's a lot of political history to that we won't get into, but I want to hear from you all about how you would characterize the state of gun violence research, and give us a window into where there are promising practices, where there might be leading edge conversations, groundbreaking work happening, given, again, this context of the lack of investment. And Daniel, I'll have you start, and Joe, I'll ask you to follow.
Sure. Well, folks should understand just how small this field was really not that long ago. It was a field that was underinvested in, and there wasn't, frankly, much hope even. That changed, thankfully. We now have a research society that we get 700-800 people, many young researchers coming to learn, to share their own research. It is a very different situation that we find ourselves in now, thanks to investment from foundations, finally some investment from federal government as well, and frankly just a need. And as someone at a school of public health, over the years more and more students show up and saying, I'm here because I want to study gun violence. And that's just very encouraging. So it's a much more diverse field than it ever was. There is a greater commitment, and Dr. Richardson can speak to the important work that his role in facilitating that. But it's a great thing to see. There's more intentionality to have greater representation involved in the research, and importantly, the closer connections to the communities where the problem is most impacted. And so I think that it's more diverse. We're asking deeper questions. We're requiring more of ourselves as researchers as we show up and try to do this not particularly easy work. That's just in general terms what I would say. But it is a very different landscape than it was not that long ago. And it's really invigorating to see.
Yes. Dr. Richardson, congratulations on your new center.
Thank you.
Would love to hear your response.
Thank you. I would echo what Daniel said. And again, I can recall in 2009, 2010, Dr. Cornell Cooper and my other colleague, Dr. Tanya Sharp, who was at that time in the School of Social Work, we would meet in Dr. Cooper's office, and there are two campuses at the University of Maryland, College Park and Baltimore, and the three of us, we were the only gun violence researchers on both campuses. So just put that into context.
Wow.
And so if I'm at College Park and they're at Baltimore, I was the sole gun violence researcher in College Park on our campus. But fast forward, and just in terms of the underrepresentation and marginalization of Black and brown gun violence researchers, such as myself and Ruth as well, in July of last year, we launched the Collective, which supports Black and brown gun violence researchers and uplifts our research, as well as mentoring the next generation of Black and brown researchers, and which Kaiser has actually supported. And I also see Tim. Raise your hand, Tim. And Joyce Foundation has supported us as well. And we recently were awarded a $3 million grant from Robert Wood Johnson to support our infrastructure. So just in terms of uplifting the work of Black and brown gun violence researchers, many of us who come from communities that have been disproportionately impacted by gun violence, it's critically important that we have an organization like the Collective to support our work. The other thing I would say is, as Daniel mentioned, just the field has grown exponentially, and I think we have much more room to grow. In terms of multidisciplinary work. We're no longer just seeing the usual suspects of gun violence researchers from fields of criminology, public health, social work, and medicine. We're now seeing gun violence researchers at our conferences that are coming from economics, engineering, artificial intelligence. In fact, my graduate student, Jessica Zhu, we recently submitted an article which revise and resubmit, actually, so it's a pretty good thing. And she's an AI, graduate student in AI. We submitted an article about the ethics of AI in gun violence research. So, we're seeing more people in that field, but we're also, I'm proud to say, just in terms of social determinants of health, some really unique work done by, for example, one of Daniel's students, Mudia Uzi, who did a really interesting study on redlining in Baltimore and the connection between historically black neighborhoods that have been redlined in gun violence research, and also Eugenia South, who's at the University of Pennsylvania, has done some spectacular work on how you can change the physical environment and how that affects gun violence in Philadelphia. And so we're seeing all of these different tentacles that are reaching out into multiple disciplines, and I'm really proud of that. And then the support that we're seeing now to increase the number of black and brown gun violence researchers.
Terrific. Thank you so much. Please, Kristen.
Yeah, I would say the suicide research world is maybe at a slightly different place than community violence more broadly, in that there has been a lot of attention to suicide prevention over the last 20 years because of the rising rates of suicide. That said, specifically there's been a lack of focus specifically on gun suicides. I would say I've been working in the health policy field for a number of years now, and I can remember about 15 years ago, the state of Florida passed a law that said that pediatricians cannot talk to their patients about where their guns are stored in the home. That eventually got struck down and had to go through the courts, but looking for opportunities for healthcare providers to talk to their patients about gun safety, about safe gun storage, about the connection between having guns in the home and the elevated risk of suicide for both young people and adults, I think has not received the level of attention that it needs to, especially, again, as we look at the stats that show that more than half of people who die by suicide are those deaths involved a gun. Looking forward in opportunities for kind of new areas of focus in suicide prevention, the rates of suicide, again, increasing across the board, disproportionately increasing among communities of color. We are seeing really skyrocketing rates of suicide among American Indian and Alaska Native people, Black people, and Hispanic people as well in the United States. And this is even while kind of the suicide rates among white people have been kind of steady. And so there's clearly a need for additional research and focus specifically on suicide within communities of color. We actually have a paper coming out in the next couple of weeks specifically on Black youth suicide that shows that in 2022, it was the first year that Black youth suicide actually surpassed the white youth suicide rate in history. And so clearly what the healthcare system has been doing, what the suicide prevention world has been doing around suicide prevention strategies have not been effective within communities of color. And whether that is the actual strategies are not culturally competent or culturally effective, whether there's a lack of cultural competence within the healthcare providers who are seeing these patients, lack of access to mental health care for communities of color. I think there's a lot of different strategies that we could really look at to see what's going on within these communities. However, it's clear that there's a need for additional attention and additional research around what is happening within communities of color with regard to suicide.
Thank you so much for sharing that. And Ruth, as we come to you as a clinician, an emergency physician, pediatric setting, there's quite a bit the sight of thinking about how research into practice, how significant and meaningful that's been. We'd love to hear you talk at that intersection.
Yeah, I think one thing that's unique about community violence, if you compare it to, I used to do asthma research, if you compare it to other places where you might do clinical research, is that you have interventions that are actually not that new, that have been implemented by practitioners who are not clinicians on the ground. And now we're trying to integrate that into clinical practice and codify what are the relevant salient portions of those interventions that need to be implemented with fidelity so that you can see a reduction in violence for your patients. And that's a relatively unique position to be in, right? The field needed to move forward because violence was at significant levels in many communities throughout the country, even though there wasn't the funding and there wasn't the investment to study the interventions the way we might do for asthma. And so what we're doing now is we're taking a look at what the community violence intervention strategies are on the ground and trying to bring that into the clinical setting. What are the pieces that are essential? What is the secret sauce for all of these interventions? And then how do we do the public health approach, right? How do we use data, take it all the way to scaling to effectiveness in a way that makes sense and in the way that we do for other diseases. Unfortunately, the idea that gun violence is a disease like other diseases is still relatively new. Most people in this room, I think, are of that mind, but that's not a universal opinion. So first we had to do kind of a hearts and minds conversation, and now we need to figure out what are the steps that we need to take to implement these strategies in a clinical setting, and that is unique in settings like pediatrics because you're implementing interventions on a community and on a family unit, right? Children are making decisions in a community. And so how do you effectively implement community violence intervention strategies that affect children by recognizing who the relevant partners are? So that's really been, I think, an area of exciting opportunity, also challenge for CVI strategies in kids.
So I know a bit about your work and some of the values of looking at innovation, research, and community inclusion and power sharing. And those are a pretty unique set of things to try to get right when we're addressing a crisis like gun violence. There's a tremendous urgency to get it right, but also a real desire to go slowly and patiently and ensure that all these intersections are working together. So I want to hear a bit more from you about how it is that in gun violence research we can conduct this work equitably with diverse populations, right? How do you do that engagement? Dr. Richardson, I'm going to come to you. I know that you think so, I think, innovatively about community engagement. Can you share with us some of those strategies, some of the work you've done on digital media, the documentary that you've produced? We'd love to hear about it.
Sure. So I think the emphasis on, we often use the term community engaged, but to borrow from one of my colleagues, Dr. Franklin Cozy Gay, it really should be about community-led and encouraging the community to lead in terms of what are the questions that need to be asked, right, that are most impacting the communities. How should they be engaged in the research design, the dissemination of the findings, and being aware of the dissemination of the findings, which Daniel and I are doing right now before they actually go public. Like, you need to have the community engaged in those discussions. And then the translational aspects of the research. So for me, I mean, I didn't really have a blueprint, but when I was conducting my study at Prince George's Hospital, one of the young men that I was in my study ultimately became the violence intervention specialist that I hired for my HVIP. And then that relationship then bloomed into a researcher practitioner relationship, which we were funded through the Center for Victim Research. We conducted our first study, which was a digital storytelling project with 10 young black men who had been violently injured. And initially we just thought, okay, we're just going to interview these young men about their experiences with traumatic stress, how they navigate dealing with their physical and psychological injuries post-discharge from the hospital. But when we finished our interviews, we still had money, a significant amount of money left, so we expanded it to include the cast of characters in the violence intervention ecosystem in our documentary, which ultimately ended up winning 3 National Film Festival awards. But in that process, the young men who were part of it, as well as Che Bullock, who I work with now on our longitudinal study of violence intervention programs in DC, I relied heavily on the young men to direct the project, right? It was community-led. All the questions, vetting the questions through them, determining what questions I should ask, what questions we shouldn't ask, even in terms of the dissemination. And so when we go out to screen the film, either in any situation, Che is with me, or one of the young men, specifically Christopher Edge, is with me when we're screening. And on all of my articles, they're co-authors, right? And I think we've marginalized the community from engaging in co-authorship and owning, like who actually owns the intellectual property. And I had to face that challenge, which I was very naive about IP as a professor. And when we started this project, I asked the IP officer at my university, does my community partner, do they own this? And unfortunately, I found out no, right? I didn't own it, and they didn't own it.
Right.
And so I think even in terms of discussing intellectual property, community-led research, and getting very clear who owns what, right? Because this research won't happen without the community involved, and they need to have ownership and a stake in it. And so for me, that's always been the guiding principles for my work, and ensuring that the community is there every step of the way.
Really powerful. Thank you so much. And I want to bring things to you, Kristen, thinking about communities of practice. You were sharing about an initiative that you lead at Pew that looks at clinical practice across the country. I'd love to hear more about that.
Sure. Yeah, we've been working over the past year and a half or so with a community of hospitals from around the country to implement if you're familiar with the Zero Suicide Framework, which is kind of evidence-based clinical interventions that hospitals and health systems can implement that have been shown to reduce the likelihood of suicide among their patient populations. This has been a really interesting process over the last couple of years, as I think anyone who works in healthcare knows that systems changes are complicated. They take time. They take buy-in from a lot of people within the system, both clinical leadership and also, I think, kind of the business side of hospital systems as well, to demonstrate to all the leadership that this is worth doing and that it will eventually save lives. But we have been really, I think, impressed with the motivation and the drive from across the country, from hospitals big and small and rural and urban and suburban and otherwise. I think healthcare providers recognize that suicide is a crisis that our country is facing, and that they have a very important and crucial role to play in identifying, assessing, and caring for people at risk of suicide. I think one in particular lesson that we have learned through this that I'd love to highlight, and kind of goes along with what Dr. Richardson was just sharing about working with communities, is the value of working with people with lived experience and how their experiences and their the lives that they have lived are absolutely crucial to the care for people at risk of suicide, whether it's a person who has survived a suicide attempt themselves or someone who's close to someone who has died of suicide. Working with individuals with lived experience throughout the clinical care pathway, throughout the whole system, and having people with lived experience at each step of the way has really shown to improve the care that the patient feels that they have received. It has been shown to help kind of mitigate or reduce the stigma that a person experiencing suicide risk may be feeling when they're interacting with a clinician. And it really leads to better, I think, clinical outcomes for the patient, and also better clinical decision-making for the healthcare providers themselves. And so kind of for people who are interested in the issue of suicide prevention and suicide care, it's absolutely essential that we do a better job of bringing in people with lived experience and really, I think, kind of authentically taking into account their perspectives and their recommendations, and making sure that they are, a crucial member of the care team when it comes to treating people with suicide risk.
Thank you. Dr. Abayo, I'll come to you next. This theme of community engagement and building communities of practice. You've spent time in Philadelphia in the health department trying to galvanize a coalition to address firearm injury. How has that work informed your work now? What are some lessons learned about building communities of practice?
Yeah, so I think when it comes to violence intervention in particular, I think that that collaboration is, first of all, essential, but very tricky, because everyone is working within an independent either organization or health system, all of which have slightly different priorities, different regional focuses. And I think also there's a data sharing piece to that can be extremely challenging. I think if we want to be a public health approach, we need to be data-driven, which means we need to be integrating data from all of these different stakeholders to understand our collective reach and our collective impact. And I think being able to do that requires a lot of conversations with lawyers, but before you even get into that, a shared vision of what we hope to actually achieve with that collaboration. So I think that's probably the hardest thing. One of my favorite stories around doing research or data collection and involving community so that it can be effective is when we partnered with people with lived experience, people who were previously incarcerated for life and were released and have been doing a lot of work in violence prevention in the city of Philadelphia, who read one of our protocols and completely changed it, right? They were able, to your point, to say, this is a terrible recruitment strategy, it's not gonna work, and this is how you really need to be mindful of what the community actually needs. We were able to disseminate that amongst our coalition, change our IRB, and do something that actually answered the needs of the community. So community has to be at the table for those coalitions if they're gonna meet the needs of that community. And you have to have a shared vision so that the pieces that you need to bring in place, such as data sharing, can actually be facilitated. And then it all requires a great deal of patience, which can be hard when the work is urgent, but I think a lot of patience to build something that's actually going to be sustainable.
That's great. I'm going to bring things back down to you, Dr. Rebster, about, again, community inclusion and data. So you've shared stories I've heard about what it means to bring data back to the community and what that engagement is like. You share some insights with us here.
Yeah, well, you know, a lot of my work has been studying community violence intervention programs, and I really wanted to inject this into the conversation because when we just say research, it's very general. When you put in evaluation, it sort of ratchets up sort of the stakes,
That's right.
Okay? And so I share my evidence with the frontline workers as well as the site directors. And, you know, in one case, I believe in 2018, 2019, I think I had a dozen meetings before everyone truly understood what we were doing and what it meant. So in the work I'm doing now with Dr. Richardson here, we're, I think, a little bit more intentional about not only gathering that data to sort of answer, okay, what impact is a program having on gun violence, but simultaneously gathering data from frontline workers about what are the unique challenges that they're facing, what do they actually need to be successful. Generally, what I found in my own work is it never works every place all the time. There's always challenges when you think about how, gun violence, geez, and we're going to hire a few workers and solve all this? No, it's really hard work to do. So I think going forward, it's really useful to combine the data that you're looking at program impacts on gun violence with this evidence from the frontline workers in a manner that people understand where you're going. Your intent is to ultimately enhance and strengthen programs so that they have greater impact, rather than you're just showing up to say, yeah, it works, it didn't work, or whatever. But it's not easy to do because, again, the stakes of evaluation makes people nervous.
That's right. More than nervous.
Yeah.
I have to say it lightly, absolutely. We have just a few minutes left, and I want to just again acknowledge each of you and the contributions you make to this small but growing field. We're in this field, sadly, surrounded by tragedy, crisis, death. And so I'd love to end on a note and hear from each of you. What makes you hopeful about this work? What, as we look out into the future, if we think 10 years hence, what has changed as a result of our efforts today? Anyone like to start? can start. Sure. Okay, go for it.
Yeah, lots of things. So
Yeah.
I'm going to give kind of a technical response and then more of an emotional response. And so I think technically, I think we are seeing fields of research that have been growing astronomically recently, incorporating gun violence into their priorities. And so there's been a lot of attention on implementation science. Now there's conversation about implementation science for CVI. There's a lot of attention on more powerful qualitative research, and that's been going on for a long time, but there's a lot of attention to that in CVI. So whatever strategies people are thinking about, whatever fields, engineering, economics, as Dr. Richardson said, we're thinking about violence now in those fields, in those areas of emerging research, and I think that's exciting. For me personally, I think it's really exciting to see that there's room kind of for more people at the table. I think that it's really great to see, I guess I would call it a pipeline of mentorship around this type of work. I remember being told when I was a fellow that it was fine to do fellows projects on gun violence, but it was not something that I should pursue as a career. And so I don't think people are being told that anymore. So seeing that development of interest and a pipeline of people who feel empowered to actually pursue this feels really exciting.
Yeah, I would say within kind of the healthcare system's response to suicide, what makes me really feel hopeful is seeing the walls break down between mental health and the rest of health, and really seeing that kind of clinicians across the board beginning to recognize, or not beginning to, they have recognized and they have started to step up and realize that everyone has a role in helping people or helping identify and care for people who may be at risk of suicide. And so that makes me feel very hopeful that suicide will no longer be, or will move away from being such a stigmatized kind of scary thing that the healthcare system is afraid to really face. And so that has been exciting. I think from a personal perspective, I think I'm optimistic and hopeful, again, just everyone that we work with and everyone that we interact with and all of the folks here in the room who have really identified this as a solvable crisis within this country, and that we know what works. We have the people who want to take the work on and to make the changes necessary. And now it's just a matter of implementing and scaling around the country so that more people who may be at risk of suicide get the care that they need.
Thank you.
I would say the level of investment in CVI just as an intervention in practice, but also in terms of the research. And again, I can recall starting this work and the largest amount that I ever had in terms of a research grant was $100,000. And usually I operated anywhere between $10,000 and $25,000 on seed grants. Wow. And so to see the field grow to you can now get a $2 million, $3 million grant to do the work is really amazing. So I'm impressed with that. Also, again, with the multidisciplinary nature of the work and people coming into it from all different angles. But I think what I'm more impressed about is in terms of the community's involvement and our emphasis on community partners and being community-led or community-engaged research, and people really acknowledging that. It's no longer performative, because a lot of times we would say it, but we would not actually carry that out in practice. And so I'm very happy to see that we're finally at the point where we are truly emphasizing that the community has to be a part of the research, and we need people with shared and lived experiences that are credible involved in the research that we're doing.
I'll just briefly say what makes me hopeful is the young people who are getting engaged on this problem, and you can think of it from an advocacy standpoint, but the people who I see at my own school showing up and saying they want to commit themselves to this issue, an incredibly diverse group. And even I have several people in law enforcement who are getting graduate degrees in public health that I am advising. They really want to embrace the public health approaches and think about how law enforcement partners, and that to me is very encouraging. Public health approaches are about system changes, and one of those systems obviously we need to change is law enforcement. And again, I'm very hopeful. I see more openings there than I've ever seen.
Thank you so much. I want to just take a moment to acknowledge not only your work, but to thank the staff who are supporting the center. For those of you out in the field who might be listening in, thank you for your work. Let's find each other. If you have any interest in gun violence research, education, narrative change, if you're curious, we encourage you, please visit us at Kaiser Permanente Center for Gun Violence Research and Education. We want to build the field, and we want to build a movement of people, no matter where you sit, that there's a role for you in addressing gun violence in this country. So thank you all so much. Please join me in thanking our panelists for this incredible discussion.